start with the financing component. And what I'd like, we have court cases at the moment whereby private sector is taking the government to court on the implementation of NHI, how it's going to be implemented, whose tax is going to be used, and how is private sector going to be affected by NHI. So I'm going to put it on you to try and tell us how you think we're going to be able to achieve this.
Thank you, my good chair. Good people, I think one of the most important things that we have to consider is that there is a bit of a response coming out of any innovation. We might have noticed that when we look at a certain commodity, for example, let's take ARVs. We initially have it placed in market responds to it, and after the response comes concerns, comes the reality of what the commodity is actually when introduced within the consumerism market. And what happens there? Regulation. Making sure that it is then monitored. Any innovative landscape and any innovative component firstly introduced into a market will have those teething problems where eventually our reality, our consciousness comes up to a point where we realize that this commodity needs to be regulated. Let's make sure that it is structured. Let's make sure that we have risk procedures put in place, we have governance put in place, and the like. Where we are at right now with the knee-jerk response going to court, for example, on the basis of the NHI, it's because it's an untested commodity. People are panicking. Both public and private sector is panicking on the basis of this new commodity. I think that there were two questions in what you had posed, my good chair. One of them being, what's happening right now and what observations do we have as specialists around the table? And the second one is the element of pricing, which in itself is an amazing menagerie of a lot of points. But I wanted to answer the reality of where NHI is right now, untested. It's something that does have good intent. It is something that at the end of the day, from an engineering point of view, we will have evangelists and we'll have critiques. But as any spirit of innovation should move forward, so too do I believe the implementation of NHI is a commodity that can most certainly benefit from galvanizing it with new technology, from us adopting it in a way and adapting it in a way. And that's one of the reasons why it's so important. The adaptation of a commodity like the NHI is going to be quite important. The moment it is in, the moment it is established, the moment it is implemented, it's quite difficult for us to change and have that malleability that our innovators would have. I think that that is something that both public and private sector needs to adopt. The realization that innovation is not static. It needs to be malleable and it needs to respond to the need of the consumer, respond to the need of the market that it is placed in. So, from understanding where we are at, from understanding what is the best position for the NHI, it's definitely a controversial topic, my good chair. I would like to contribute that element. And I think on the pricing, well, there are a lot of very creative models. We mentioned PPPs in the sense of private-public partnerships. We mentioned potentially considering globalization with respect to the origin of funding without relinquishing our sovereignty as a nation, without relinquishing critical data. There's a lot of explorations, but I am not going to steal the spotlight, and I'm going to also allow my colleagues around the table to segue into that as well.
Wesley, my dear, I'm very sorry. Please welcome Wesley. You've already met Wesley. Wesley presented this morning. And Wesley is a life science and healthcare leader at Deloitte. So what he's going to help us with is how we are going to deal with the infrastructure that's going to enable NHI to really succeed in this country. So I am definitely going to put him on the spot and help us with that. Thanks. Okay, Wesley, I know I'm sorry for not calling you on time, but please, before you sit down and you get cold, can you start with the infrastructure issue? How is the infrastructure currently going to help us to deliver NHI? But also, what is your suggestion in terms of how we can improve the infrastructure? Thanks. And both the digital infrastructure and the actual connectivity modules. Thanks.
I'm really regretting coming to sit here. Okay, let's go. So in terms of infrastructure, there's two parts. The first one is talk about the digital infrastructure. We do not have that at the moment. Not one particular player has any sort of bandwidth, to excuse the pun, to invest in that. So we need to look at incurring technical debt through strategic partners. Our hyperscalers have to put some stick in the game, such as, think of a hyperscaler, think of people you use, I can't mention names, but the people who can handle cloud services can invest in major infrastructure to handle data processing, data warehousing, data aspects for things. Governments don't have the money. I don't have the money. And so we need to have that sort of out-the-box thinking towards developing an ecosystem that can support this. In terms of infrastructure, in terms of facilities, etc., we have to get real. If facilities are not up to scratch, they should not be used. If the quality of care is not there, we have beautiful examples of innovative ideas of decanting the health system to where places can be more effective quality of care. So infrastructure is a get real. And in terms of digital infrastructure, we need investors from hyperscalers.
Thank you, Wesley. I'm going to move over to Luba. Luba, I'd like you to explain. Luba, please tell us how you're going to bridge the gap between the urban areas and rural areas. I mean, the places where you've implemented in places like Eastern Cape. As we speak, the Eastern Cape is one of those provinces where really it's like we're living in two different worlds. How do you think NHI is going to be able to bridge that gap between what's available in urban areas and what's available in rural areas? And how do we bridge that gap? In your experience with what you've already been implementing, how are we going to do that? Thanks.
Thank you so much. I think from what we've been doing for the past 11 years, we looked at how do we actually stretch resources, because we know that there's already budget constraints, but there is a myth that there is no funding. There is funding, but it's going to the wrong things. I'll give you an example. Government is sitting at 77 billion rands medical legal claims, and they're struggling to actually contest those claims because, one, there are no adequate records. So when we talk healthcare, we need to start at record keeping, but how it's done and everything else, it becomes something else. You find that one patient has 10 different records, different information. So at the point of care, take for example a car. You have two cars, one with the service history, one without. So the one without the service history, the mechanic has to check everything, wasting time and resources. But the one with the service history is just much easier to get to the problem. So once again, you've saved time, you've saved resources. So this is what we've discovered as well in the rurals. Every time I go home, I have to say to my mom's friends that are in 60s, 70s, no, I'm not a doctor, because they will come in numbers. I've been on this treatment for my diabetes, but I'm experiencing GI side effects. I'm experiencing this or that. So they can already see that there's a gap in terms of patient education. And it means that whatever treatment they're taking, it's being wasted because there are no clinical outcomes, because it's the wrong dosage. It's never been titrated for the past 5 years, still sitting on the same treatment. A second one, we find that they skip, script renewals because of different challenges. One has to find a childminder for them to travel 2 hours to queue at a clinic just to renew a script, something that could have been done virtually. I'll give you last one. A patient last year, she traveled 14 kilometers, 8 months pregnant, just for a normal checkup. These are all things that can be packaged and actually easily distributed within, the low, the hard-to-reach areas. nurse-led programs, training of unemployed matriculants actually to take vitals in certain communities. So we've built a model that is nurse-led. So what we do is in the program we train matriculants as community healthcare workers. They help in terms of data collection because there's literally nothing they type in or they write because we're using tech. So tech, we just go there. If you are asked to take, you train them how to take temperature, how to take BP, how to take these specific biomarkers that you would need in terms of decision making. And technology has really helped in terms of that. And we're able to put all that into one system that actually analyzes that, and also have a network of doctors that are not in those areas, that they're able to pick certain cases, and then a consult is offered virtually. A consult that is more informed because there are vitals during that consult. So there's many applications that we've used technology to show that the gap can actually be bridged if we use technology effectively. And one last point, one would argue that in rural there's usually network issues, etc. We've actually came up with USSD option for those that don't have smartphones, but they can still interact and get healthcare using SMS functions, press star 120, etc. You can book, you can send your vitals, you can get patient education, still the same way that you would access those through internet or through WhatsApp or any other internet-driven method. So yeah, there's a couple of things that we've done to bridge the gap.
Thank you. I'm going to ask a question to the audience before I call Gilbert, because I'm also going to put him on the spot. He's no longer with the Department of Health, but he was there, so he's responsible for some of the failures and the good things that they did. How many of us in here know that we have a digital health strategy for the country? And how many have seen it? Okay, how many know? I think there are 4, 5. Okay, how many have seen it, have read it? There's one person who's read the digital health strategy. Or 2. 3. Where's the third one? Oh, Doc, you've read it. Thank you very much. So let's ask Gilbert, as an informatics specialist, how are you making sure that all these people who are interested in the healthcare spectrum and who are providing services in the digital health space understand what the strategy for the country is and how we can navigate the strategy to make sure that all these things I said when we started to say you have different provinces, different systems, please help us understand how we can actually follow your strategy and see how we get along. Thanks.
Thank you, Doc. Hey, what a difficult question. The strategy that we have currently, it has to be revised. So basically that strategy has passed its lifespan. So I don't think we can talk about it now because it has to be revised. But I'm going to give some of the platforms, information about some of the platforms that I think should be beneficial to everyone who is in the digital health space in the country. We've got the National Health Systems Committee that is been driven by the Department of Health, which meets quarterly. And I think there is private sector representation in that committee as well. And that's where things like these e-health strategies or the digital health strategies are discussed. But beyond that, I think I'm going to take this opportunity as well as the Secretary of SAHIA and say that SAHIA, it's here as well to assist everyone that is in the digital health space to know about such information such as the digital health strategy. We need to come together, unfortunately, because we've been working in silos and we've been fragmented. So we couldn't have cohesion if we don't have any platforms that bring us together from different spaces, which includes the private sector, the public sector, and the other academia as well. We need to come together and work on taking digital health forward as a country, not even looking at the public sector or the private sector. We know the public sector is responsible for coming up with the legislation, and we have to also be able to input into the development of those legislation. Universities play a role, and also the private sector play a role in developing such legislation. So I'm going to throw it back, Doc, to the audience and say that it's our challenge, all of us. And I think as I hear, we are taking that lead to say that let's come together and build the digital health platform or the digital health strategy of this country together, led by the Department of Health, of course. But we need to come together, all of us. So I think that's where I'll start from that point, Doc, to say that we've seen failures in terms of implementation of different strategies. We've had interoperability guidelines. We have had telemedicine that didn't really go as it planned. Dr. Mulefi tried very hard, but we can still say in this country we don't have that strong foundation that we can say our telemedicine or telehealth, we've got it here. We can actually just build on top of it. We've got other countries that are in Africa that have even surpassed us as a country. They are leading in terms of innovation around the space of digital health. So it's time for us to come together and build digital health in this country together. Thank you.
Thanks. I'm going to disagree with him a bit. There is no revision of any strategy. This is the 2019, the strategy that was published in 2019 is the second one. We didn't implement the first one. Now we didn't implement the second one. Then we are going to revise. No, we're not revising anything. We're taking all this and looking at what can be implemented. And I think one good thing that you said is that we needed a triple helix model where you have public sector, private sector, and then academia and research institutions. And I'm putting it back to you, Doc, because interoperability has been one of the key issues that make everything not work in the country. So how do we do that triple helix model, but satisfying the private sector as well, because private sector is about the bottom line. And we still have to care about our patients on the ground. So how do you make sure that there's interoperability? And having looked at all the things we've done, CSIR has looked at this, where we talk about normative standards. How do we make it work? From a man in the street, we can't talk academic things when we can't implement them, because that's why we don't implement strategies.
That was a brilliant point. And I think we all were going to come to a spot where it would be easy to answer the question to say we just need standards, everything has to have a standard. But I love the fact that our good chair asked, okay, we talked about standards, but let's look at reality as it relates to our standards or our intention to implement standards. It is true that when we look at any sort of implementation model, there are certain critical success factors that must be in place before we can even go down that journey. For example, we've mentioned digital healthcare strategy, we mentioned NHI. Governance, risk, controls, the GRC landscape. Does it even exist? Did we construct that before we jumped onto this journey? Did we actually normalize the standards even before we took the first step? Infrastructure, that's the second element. Do we even have the infrastructure which would dictate a success model on the basis of our intention for any standard? Connectivity. Do we have the infrastructure as well as the basis for allowing that connectivity to happen? Securitization. Do we have the methods? Do we have the knowledge to actually implement the securitization models that are needed for the continuation and for the implementation? What about sustainability? Can the model be sustained? It's wonderful implementing a model, but then 1 year down the line collapse. Now, let's talk about an expansion of consciousness if we are going to go down the journey of implementing a strategy, a model, or otherwise. There are various elements which sit within various domains. We had a natural segue when we talked about health, and we spoke about technology because we acknowledge that there's innovation needed within technology. The NHI notwithstanding, and our digital healthcare strategy notwithstanding, digital healthcare strategy. There are so many vulnerabilities within the digital environment that we need to be aware of. But what I'm noticing, and one of the things we need to guard against as leaders around the table, is that we have a one-track mind. My good colleagues around the table here mentioned silo mentality. That's exactly it, right? What we had just gone down the path of explaining in these few elements, in these few critical success factors, they don't just sit within one domain. These are various domains and an expanded consciousness of the implementation of strategy. And I must say, there has to be an appreciation for that before we even take the first step down implementation. So, interoperability in summary. That in itself has to consider all of those critical success factors in order to determine the vulnerabilities that we will be exposed of. Best to ask what will cause us to fail so that we can ensure success.
Thank you very much for your clever answer. Luba, I'm giving it back to you. Luba, the previous speaker who was talking about very nice project of clinics in the Western Cape said he doesn't like telemedicine. But the reality is we don't have any other solution. And in South Africa, actually, what he said is true. South Africa was leading in Africa in terms of introducing in 1998, we had 28 sites which were implemented by the Department of Health, where we trialed tele-ultrasound. All the digitized medical equipment was trialed in 1998. I just want to give Luba something to tell us about, in the rural area, you actually innovate even better than people who have access to things. I think in 2005, which is 20 years ago, I presented in the US and I said, in the military, and I said, we are doing teledermatology by taking a digital camera, taking a picture of a lesion, sending it to UCT, the dermatology department there, and then reporting the nurse at whatever clinic. We gave 7 nurses in 7 different districts to then send an image, just as an attachment to UCT. And we're able to treat a lot of dermatology patients, and guess what? They said you don't follow standards. A year or 2 later, when they were in Iraq, now in whatever war, they've been in so many wars, I don't even know which one it was. But when they were at war now, they were using our system, which was innovated because we didn't have the technology. So I'd like Luba to tell us about innovations that we can come up with without, we don't have to follow any body standards if it works for us and for our rural patients. Please.
Thank you so much, Doc, for that. I spend a lot of time each year in China. I do about 2 to 3 trips, mainly just to look at the way they do things, and obviously no country is the same as the other. One thing that we have a problem with in South Africa is we spend a lot of time planning, and there is a concept, a philosophy that I always share with my team, that it needs to exist first, and then we can improve after. And we end up, at times, we spend a lot of time talking about the improvements, regulations, standards, etc. But how do we plan for something that doesn't exist? So that's where we get lost. So in China, what they do is they have a committee that would sit and decide, we're taking this route, let's pilot. Okay, come back, feedback, and then change. If something's not working, they scrap it. Okay, what is next? And that takes weeks or months. It never takes years. In South Africa, we're taking years just to make simple decisions. So that's one problem. So what works in rurals that we often don't understand, there's this perception that there is no money in rurals and townships. In my village, there is a minibus that leaves every Tuesday from Libode to just the border of KZN. There's a GP there that has like a full-on practice, so he really takes care of his patients. And that minibus is packed, and the consult fee is actually 2 times less than the transport to get to that specific practice. And I tell you, no credit card is used because they don't have credit cards. There's no loan. So it's money that they actually keep so that they can procure those services. So myth number one is that there is money, but we need to cater services according to that specific market. So this is what we've realized in those markets, and that we need to create something that talks to that specific market. And once we do that, you actually see adoption. For example, coming back to telemedicine, if you're going to implement telemedicine as it is implemented in first world countries, it is never going to work. So, for example, in our network of doctors, we've actually grouped them nicely in terms of gender, race, language, etc. It's much easier to consult in your own language, and it's easier to understand certain things. There's certain terms that you can't necessarily explain from closer to English, and you would need someone with that background. Now we're removing those geographical barriers, you know. And then another thing, coming to pictures, the example that I've just given, when we think of telemedicine, we're just thinking of virtual care where you're sitting on the other side and it's just a video and voice consult. And it can actually be way better than that. And also you get to save time when it's less of a voice and a video, where a patient can actually capture, especially when we talk sexual health, you're talking about STIs. One is more comfortable taking a picture and then giving a description and how they're feeling, or a voice note, and then they send through. And then on the other side, the healthcare professional interprets that, and then the response is sent back. So there's many ways to actually cater for different markets, but one-size-fits-all approach, it never works.
So Wesley is going to tell us, he does monitoring and evaluation of health systems, and the major crisis in terms of healthcare professionals accepting digital health is change management. And I know Deloitte has done a lot of work in change management within the healthcare sector. What can you tell us in terms of implementing NHI? How are we going to use all those M&Es that you've done, and how can we learn from that without going and repeating the same things again and doing other studies?
I think that it comes down to the word value. So is there any, we're clinicians over here and we work in the health space. We do this not because we get rich. We do this because it matters. And so we'd rather spend time with a patient, helping a patient. The reward of that is much better than monetary reward, holistically. To get buy-in for using any sort of digital aids, anything that gives us back value from supporting the patient in front of you for well-being is something that's going to be adopted. And in terms of change management, there are many different AI constructs that have been put in place from Deloitte in terms of global, which we have access to, but infrastructure components are very difficult. The voice to text, the digital scribes that actually populate your medical record as you're going. And clinicians sit there and have a normal consultation, write your notes. It's populated with your ICD-10 or 11 codes, your CPT, the conclusions, etc. And then the clinician goes back and can verify. There's also ones where there's AI tools that come back on top of that and say, well, based on the person's history, you should ask them about cholesterol. They've got a familial history on cholesterol. And those are all out there. So the future is here. But the value is on how does the clinician get involved with that. Once the clinician has that, a nurse gets involved with that, a pharmacist gets involved with the value, adoption is a lot easier. So change management is about buy-in more than anything else, and not just a stick.
Thank you. We've got 5 minutes left, but I'm going to open it up to the floor. If there are any, key questions that you'd like to ask to my panelists, so that we can get value from what you got from what they were saying, and maybe come up with at least one thing that we can say after this conference, this is the one outcome that came out of this panel discussion. Thanks. So I'm opening it up. Any questions from the floor? Are you scared of them?
Hi all. I'm not sure who this question will be relevant for, but whoever is game for it, please go ahead and answer. But I just wanted to ask about electronic health records and where we are in our country in, getting all the records in one place and having them easily accessible for clinicians.
Please. Since we're talking about that, there's someone who has worked in the public sector. I just want to know, especially with regards to how things are captured currently in the public sector. Member information, those kind of things. We were talking about AI and want to build robots and all that. but I feel like we're a bit behind. What are we doing with those kind of issues that are there currently? We're capturing member information on documents, on papers like this, and we're talking about data. Is there progress? What are we doing with that kind of problem? Because AI should be solving issues than just it being. We don't just want to see robots running around.
Mine is also looking at NHI, but from personal side also is that the speaker spoke about he takes 2 trips to China, comes back, comes with an idea. But if you look at the grand strategy of China, communist world, money goes back to the people. In our case, but controversial what I'm saying, money dissipates, it disappears. And these are the funds that is taken away from my people in the Eastern Cape. And the sad thing about it is the money that disappears is what should be reinvested. If we go back to all the SSMEs, those are money that should come back to the country. And that is China's strategy. And that's why they can implement, rework, and modify. We're not there. I think before we go digitization, we should look at changing our mindset in South Africa and in Africa. And that's how we'll go forward. At this moment, we're speaking all of these concepts, but we're not looking at the point. Our digital strategy was written in 2016. WHO said there was no work done on it for the whole period. So we're going to sit here and discuss, and if we can't get the silos away that we're all speaking about, we're not going anywhere. Capturing of patient information happens on an A3 book. It gets lost, and we're stuck behind. Rwanda, Jean, used Skylink. We're pushing Skylink away. I'm not saying Elon should come. I said, what do we do about it and how do we use it? Do we want to create, and apologies, are we looking for the next tender to come? And that is what we need to do, and that is the grand strategy of China. Help my people to prosper.
Thank you. Unfortunately, you didn't say who you were. Please.
I'm Fernando Williams.
Pardon?
Fernando Williams.
From which organization?
Private hospital.
Okay. Also the 2 speakers, if we can just get who you are, so that when we write a report on this. I think I'm going to give him to respond to that, but I've got something to say about
Okay.
I've also got something to say about the fact that we want to implement. I mean, you go to medical schools and schools that are nursing colleges. They're not being taught how to use even a computer. So how are we expecting all these healthcare professionals to one day come out as doctors and now start utilizing all these technologies that we are suggesting? So that is one of the key things that came out from what you've just said. Thanks.
Thanks, Doc. Recently, we had a nursing symposium, and one of the major points that came out of that nursing symposium is that there was even a representative from the South African Nursing Council. We agreed that there needs to be introduction of nursing informatics at the in the education sector. So we are going to address this issue of having our nurses not wanting to utilize the technologies because they find them, they add more burden to their work. So we want to automate certain processes and give time for the nurses to look at to do the clinical, but also they must get used to utilize technology. So we're approaching it from the education point of view. So yeah, we are going to address that one. And when I'm saying we, I'm talking about SAHIA in partnership with SANG, and also we have to involve other partners in the space so that we can work together. And then on electronic health records, let me just put a disclaimer. I'm not representing the government. Yeah, but I work in the public sector, so that's why I have I have that information, and I can say that in terms of electronic health records, there is currently a project on developing electronic medical records. It's being piloted in Free State and also in Mpumalanga. And I'm not sure about the plans in terms of scaling up at the moment, as I'm not in the system, or I'm not involved with the custodians of the project. So, but there is that project to develop electronic medical records, and it's been pioneered together with the Department of Health and CSIR. They are developing that. And in terms of capturing of data, Mr. Maila, we are looking at utilizing, I think that the plan is to utilize the same electronic medical record to ensure that we've got one record for each person in the country. We're not sure how long it's going to take, or if that is going to be successful as well, because it's a project that they are building it in modular phases. They add more modules as time goes on. So we'll see as time goes on as to whether there will be an electronic health record for the country. But I have to indicate that I've seen some of the good work that is being done in the private sector, like the Netcare system. I mean, that's the first time when I saw the presentation on that system, I asked myself as to whether can't we have triple Ps, because we don't have to reinvent the wheel when there's already tools that can be utilized. So from Netcare, earlier on when they presented, I wanted to ask the question about private partnerships, public-private partnerships, but I was like, no, let me leave it. But I think as Netcare we even working on having a webinar where maybe we can invite Netcare to come and present that to the public sector representatives, majority of them, then they can see what is happening in the private sector, and we see how we can take that forward as a country. Then we can establish, we can use tools that are working, because the one that has been developed, like I said, it's not really, we're not sure if it's gonna work. Yeah, so yeah, that's okay. How I can wrap up around those questions.
Thank you very much. I know Wesley is dying to say something, but I'm just going to say, Wesley, don't tell us about pilots, and because if we start with pilots, I'm going to tell you how much money South Africa has wasted on all these electronic health systems. So tell us something, nothing about pilotitis. Thanks.
But the airlines are grounded now because of the navigation systems and the pilots. You still haven't used that. So just for clarification, the National Department of Health is a shared electronic medical record, which is a smaller version of the EMR. It's focused on if a person in front of you is lying down unconscious, you need to know who they are, you need to know what medication they're on, you need to know what laboratory tests are available to you, so you can make a very good decision. And they're trying to incorporate PACS. That's space for each one of you in here in terms of your switches, because that information gets taken up into those things. And the standards are all HL7 Fire and ISO standards compliant, number one. Number two, from an auditor hat, I'm looking straight into you in terms of, and maybe just to the audience, throwing digitization at a problem doesn't solve the problem. Any one of you have implemented something, you first fix the processes or refine the processes, and then you digitize. That's something we have to do. Audit hat from Deloitte, if you look at the audit reports of the National Department of Health and the provinces, etc., National Department of Health administrative fees about 3% of their total budget. It is tiny. If any of us could run a business on 3%, we'd be very happy. The only province that rivals that is Western Cape. Every other province, the cost of using our equitable share is in the double digits, and that's wastage. And that's money that could come back and fund a lot of initiatives. So we need to look at the processes from how we spend our money.
Okay, thank you very much. I'd like to thank the panelists, but I'd like them at least to, each one of you, if you can give us 2 points on email to the organizer so that we can say, out of these, next year when we meet again or any other, we can say, what have we achieved so far? And we must not build, Rome was not built in 1 minute. So let's do it stepwise, but let's look at the critical issues that you as panelists have spoken about, but what has come out of the floor as well, in terms of how do we get ahead? Because NHI is here, it's coming, whether we like it or not, whether in 10 years, but it is what is needed. Our patients we don't have access to healthcare. Equality is important for South Africa. Thank you very much, and I'd like to thank the audience as well for being kind.